Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
Hello?
Hey.
Dr. Mark Vaughn and
Dr. Gwen Vaughn.
Telling you about the digital rectal examination as a tool for specifically detecting prostate cancer as a screening.
I find it interesting that you're pointing like this.
With my... Oh yeah, I get it. Let me put that away.
You had to be like a politician. Where they point at you without pointing.
I think it was...
It's the no finger pointing.
I think it was Bill Clinton who did that a lot back in 92. Yeah.
That would be when he was like.
So thank you for coming to the show. We are going to talk about specifically the evidence for or against and decisions made regarding using a digital rectal examination for screening for prostate cancer.
Is it number one?
And we'll also touch on our comments because this is a live program when we're making it. People on YouTube can chat in. If you want to make sure you're a part of that in the future, be sure to be subscribed and hit the bell icon so you get notifications. But generally, it's 4:30 on Mondays, Pacific time. So we do have a comment already. And it's from Lindsay Antwine.
What's that?
Because she's feeling slighted that we don't have a live rectal examination during the program. And I don't know. I guess we could demonstrate on the mannequin. I don't think it's perforate, though.
I don't think so either.
So it's not perforated. So we're not going to make it. So did you bring your drill?
Perforate it yourself.
Yeah, it's just not going to. I'm sorry, Lindsay. I'm really sorry.
Yeah.
But we do welcome the comments nonetheless.
Yeah.
Even though we can't give you all your heart's desires, but we will.
I'm sure that's what they desire.
Yeah. Should we get the jokes out of the way up front? Or
there's the joke
or
right
should
there.
we wait till the end?
Oh my gosh, I knew it was heading there.
It made me laugh. Okay, so Dr. Gwen came up with today's topic. I didn't. I was going to talk. What was I going to talk about? Brain abscesses in kids.
Brain abscesses
in New York, something like that. So the rectal examination, I was taught that it would be a part of screening of all men over the age of 50 for specifically prostate cancer, the number 2 cancer in men. I think it's both number 2 and the number 2 killer. Yeah. Number 1 is skin cancer, the number 1 killer being lung cancer. I believe that's how it works. Does that sound right to you?
Something like that.
So prostate cancer is not in the top 3 for women, by the way.
Strangely.
It's not.
Yeah.
It's others. So more so a men's cancer. And we've talked about it so many times on podcasts and on this program about how prostate cancer, even though incredibly common if you look at prostates just to see if cancer's there or not, like an autopsy series or something like that. But it is not, and then right after I say it's the number 2 cancer killer, even though that being the case, it is not that huge of a killer relative to how many prostates you check have prostate cells in them, like prostate cancer cells.
Yeah.
So we are learning more and more that prostate cancer is something that men die with, not something that men die from.
Sure.
So it's frustrating, though, because it's hard to tell a patient, well, we don't do that anymore. Maybe they're used to having this exam done in the past or by a different doctor before they came here. And you say, no, we don't routinely get PSA. We don't routinely do a digital rectal examination, at least not for the purpose of screening for prostate cancer. We may do them for other reasons, or if it's not for screening, maybe for checking the
size of the prostate,
current status of it.
If it's infected.
Yeah, or if you already have known cancer, there might be a reason to, or if some other thing is going on, but not for the purpose of getting somebody who's just coming for the routine checkup and doing the examination. Then they ask, well, what do you do? How do you find it? And unfortunately, I say unfortunately, hold on, we'll get back to that part. The answer is, once it's spread and it's too late, I know how it sounds, but here's the thing. Again, it's so few people of those who have prostate cancer, even though it's the number 2 cancer killer, people are dying from other things. They're dying from the number 1 cancer killer. They're dying from non-cancer killers. They're dying from COVID over the last 3 years. So these are other things, trauma, that are killing people that are more likely to happen than to die from their prostate cancer. They're more likely to live with. So, yes, it sounds bad, but relative number-wise, it's not that bad. And so you may say, well, why don't you? I mean, why do you not catch it? It's because it's uncatchable.
What's your problem?
Yes, as the studies are going to help us point out that, yeah, you'll find positive tests. You'll find positive tests when you do the finger exam. You'll find positive tests when you do the PSA exam. But these are not people who are going to die from cancer. And to pursue the high PSA or the digital rectal exam and do the workup, you're putting somebody at risk for bad things.
Many side effects.
Not that urologists are bad, but really, in the last 30 years, a lot of people have had things done to them that really were bad compared to if they hadn't had attention. And I don't mean to pick on the urologist. It's just it's their specialty. They do it. We love our urologist. He's a great guy. And in fact, I'll probably end up being a patient of his someday. Who knows? But for him to be getting all of our patients who would have positive PSAs and positive digital rectal exams, there's going to be a lot of people who are going to undergo very serious treatments with very bad adverse effects. Incontinence of stool, incontinence of urine, impotence for the rest of their lives for something that they wouldn't have to go through that if we didn't even do the screening in the first place. So that's the reason we don't aggressively try to get those very, very, very few who would actually get harmed by the prostate cancer. I'm sorry. I just kind of get it all out there. Okay, so let's... Are you ready to talk, or do you want me to check the comments?
Oh, I can talk a little.
Okay, we'll come to the comments. We're coming to you, Lindsay. Okay, so go ahead.
First of all, a little background. The prostate is... We probably should have started with this. The prostate is a little gland that sits right below the bladder.
Sometimes it's a big gland.
Sometimes it can get bigger. Most men, actually, if you live long enough, are going to have a big prostate. That's just natural for it to get larger. And that is one of the reasons we do a rectal exam to see how big the prostate is. But it is right there. The reason we can feel it is it sits right in front of the colon, just inside the rectum. So you can place a finger in there and feel the size of the prostate. Which is useful for a lot of things, but turns out it's not useful to detect cancer for a few reasons. One, you're only feeling the back of the prostate. Studies show that, of those who we kind of find cancer in, only 28% actually could feel an abnormal, or had an abnormal digital rectal exam. 28%, that's not even half. I mean, that's abysmal. I mean, we're not even catching it. So that's one thing. So that's a reason against it, that we're not even going to catch most cancers with a digital rectal exam. And then also along the other side, PSAs are much more sensitive. We've talked about those in the past, and they have their issues as well, lots of false positives and other things. But, it doesn't always match up. Even when you combine them together, you don't always get, you can have an abnormal DRE and an abnormal PSA and still not have cancer. When all is said and done, it's tough to find these things.
So how do we address Lindsay's question about, so how do you decide who does need treatment? The handful of guys who actually would benefit from treatment. Excellent question. That's we wanted you to ask that question, actually. So what would the answer to that be? You want me to?
Well, we don't. It's kind of the long and the short of it.
There are ways of dealing with it. So.
There are. So the urologists have a few other ways of grading prostate cancers that are found. They have these scores that they give them based on a variety of factors where they can see that it's maybe a little more aggressive and find those. So that is more, that's like a second step besides just doing a PSA. As primary care physicians, our whole thing is screening and actually finding these things in the first place. So that's kind of where the tough part is. There are going to be those who may be missed if we follow the recommendations, but it's going to be a very, very small minority. And when we're looking at studies and everything, we need to take everything into account. You know, as a primary care physician, we are in charge of the whole body, the whole health of our patients, and we don't want to put our patients through things that, you know, may cause issues when it's not needed. So we have to take that into account. And plenty of studies have been done on this, and when you look at it, you know, almost every major governing body out there says don't do a DRE. It's not helpful. Now, PSAs have their own issue, and they say, okay, maybe have those. Make sure you have a discussion about it. Make sure you have informed consent from the patient because of that reason that you may lead to unnecessary biopsies, false positives, stuff like that. But DREs, no, don't do them.
Yeah. And we're talking about general screening. We will still do a PSA or digital rectal exam in somebody who's got other things going on, or somebody who has a bad family history, or is having some symptoms suggestive of, or the combination of the two. A lot of times we'll refer people to a urologist if we have concerns. So when we're talking about the not doing on everybody, we're talking all comers. So we do treat people differently according to their risk factors and their symptoms. Yeah. And I was going to say, you were talking about the Gleason scores that the urologists use. Actually, it's given to them by the pathologist after they get biopsies. They will look at things like that. They will look at PSA values over time. They will look at symptoms over time. They will look at imaging over time, including PET scans.
Yep.
So there's lots of things that they can do to look for the behavior and see what it's acting like, instead of just treating as soon as somebody has a suggestion that they might have a cancer. Again, because a lot of prostate cancer never harms the patient and they die with it. Most prostate cancer does not harm the patient's health, is the bottom line there.
Yeah, we're finding that it's becoming more common to have active surveillance rather than going straight to a procedure. Active surveillance is basically what it says.
Active surveillance, that's nice. I like
it sounds nice, huh?
Active surveillance.
But essentially the urologist typically is watching that PSA very closely, not going straight to a biopsy or doing a biopsy and then monitoring. Because they find this diagnosis of cancer, but we don't know how aggressive it's going to be, so they'll watch it every 6 months, every year, depending on what they see. And that seems to be where most prostate cancer diagnoses are going these days, rather than going straight to big interventions like radiation, prostatectomy, things like that.
Yeah. We have a comment here by Elaine Riley asking, do you think testing is overdone for a lot of things?
By some doctors.
Should we talk about other fields where it's occurring? Like, have you ever taken an animal to the vet?
Oh my gosh. Yeah. Well, yeah.
Okay. I can only speak from my limited experience.
I have similar experiences too.
There may be a movement within veterinary medicine to not over test, but it does seem like the whole thing that's happened in medicine of finding that we're testing to the point that we're harming our patients.
Yeah.
And a lot of the tests are actually costing medical care more money instead of saving money.
Right.
Because there's an expense to the tests also. And in veterinary medicine, my experience has been they have no understanding and no communication within their profession of there's a reason to test, the pre-test probability and post-test.
Yeah. Is that
this whole world of deciding what test should be done and when a test shouldn't be done, that it might give you more likely a false positive or not even be helpful in the first place. If what you're finding, yes, it's there, but is it going to harm the patient?
Yeah, so let's talk a little bit about that. We have patients who come in and say, oh, my last doctor every year would give me a full panel of all these tests that included blood count, thyroid, comprehensive panel, and lipid. Yeah, and we used to do that. However, we find that, like you said, the pretest probability of something being abnormal is low without symptoms, meaning that if we find something, it's maybe more likely that that's a false positive. If you're not feeling abnormal and say, oh, well, let's get a thyroid test, and that thyroid test is abnormal, and we go ahead and treat it, we actually have the possibility of hurting you rather than helping you if you're not feeling anything. So there are things that we do screen for, and those are recommended. We follow those guidelines very closely. For example, blood pressure, diabetes, what are some other blood tests? Cholesterol, routinely, things like that are recommended, and we watch those very closely because we know that those are asymptomatic. We can find those and actually do something about it. But most other things are accompanied by symptoms, or they have some other recommendations there on how to do them. So yes, we don't test for everything, and that is a blooming, emerging field that everybody's kind of getting on board with, or we're trying to get everybody on board.
Yeah, it's an interesting thing that our tests are not 100% sensitive and 100% specific.
Yeah, it's a hard thing to
far
understand.
from it sometimes. Yeah, and it's a hard thing to deal with, to know what to do when you have to take into account that imperfection of the test. And one of the ways is, like you said, check the pre-test probability. If it's likely to be positive based on the clinical picture and it comes back positive, that's a positive. If it's very unlikely to be positive based on the clinical picture, and so your pre-test probability is very low and the test isn't all that specific, you may have a 50% chance that what the test tells you is right or not.
Yeah.
So it has to do with statistics. It's complicated. It's not all that easy to take in the first dose. I like to use the example of HIV testing in the early mid-90s, where the percentage of the population positive for HIV was incredibly small, a fraction of a percent. Mm-hmm. And you would take all comers and you would test them for HIV, and most of your positives, when you're taking the general population, were false positives. Mm-hmm. And back then, they would actually go over the results with a person before doing the second test, which now we do that automatically. A positive is run through the confirmation test. But back then, these Western blots were brand new back then, and expensive, and we didn't do them on everybody. So they came up with, hey, if you have these risk factors, things that you could get HIV from, because it was very definitely something that required some kind of bodily fluid exchange to occur. If this person's having no bodily fluid exchange with other people and is not at risk for it, they don't work in first responder or something like that, where they're exposed to people's bodily fluids or doing personal activities where they're exposed, they don't get it. Mm-hmm. Those people don't get HIV. If they're not even at risk for a needle stick, then, which is very, very low risk, by the way. Right. So if you can take all of those people out and then just test people who have risk factors for it, all of a sudden, your specificity of your test increases dramatically. Yeah. Same test, but picking your population to test.
Right. Yeah, and those are things that we're taught in medical school to learn about these tests, specificity and sensitivity. We've talked about them a little before, but it essentially is the probability that a positive test equals a positive disease, and the probability that a negative test means you don't have the disease. So,
boy, that's keeps coming back.
So that is something to take into account with any test we do, and we do consider that.
So some people saw a preview of Lindsay's comment. At least we have PrEP now.
We do have PrEP.
So we should probably tell what PrEP is, since Lindsay brought it up.
Pre-exposure prophylaxis.
Yes. So I think she wrote that during the HIV discussion. Yeah. Pre-exposure prophylaxis being taking a medication. I believe it's an antiviral, if I'm not mistaken.
Yeah, it's one of those antiretrovirals.
Taking a medicine if you know you're going to put yourself at risk for getting, in this case specifically HIV, so people with high-risk sexual activity or not using protection, or that alone, but it could be even worse if you're in a higher risk population. And then if you take this medicine, very high degree of protection against getting HIV in the first place. So we do encourage people who are engaging in high-risk behaviors. If you're going to be doing that, you at least get this PrEP, so that you got a degree of protection. Actually, pretty good.
Yeah,
numbers on that.
Mm-hmm. Yeah. So we went
everywhere. I mean, from the back to the
DR.
front.
Oh gosh.
So I was reading and preparing for today's show, and some of the studies have different arms. You've got the arm with the treatment and the one without, or in this case, it was the one with the test and the one without, to see which arm of the trial has better outcomes for the patients. And it said, what was it again?
The study arm.
The study arm. And at first I thought, well, when you're doing a digital rectal exam, really the finger alone should be sufficient.
Groan.
That was my thought.
Yeah, you go. And it should be steady.
Don't need the whole hand or arm, just
steady.
Okay,
Yeah.
moving on.
Make sure
Thank you for
it's
watching. by the way.
after you've had your caffeine.
And thank you to those. Speaking of caffeine, thank you for those of you who give us the Dutch Brothers, people who are on Patreon. And you too can join them and get your name at the end of the video, as you'll see shortly over here in front of Gwen's area of the video. You'll see the names of people who actually do participate in that and help us to get our Dutch Brothers before the show so that we, well, hopefully it makes it more interesting. What it would be like if we didn't. We probably wouldn't be as
asleep.
animated. We probably wouldn't be as quick coming up with
pretty
things like
animated.
Gleason score.
Yeah.
Yeah. Okay. So thank you very much. Dr. Wayne, did you have anything you wanted to get out before we?
I don't think so.
Okay. We may not have a show next week because of not having both the doctors in the office, but
Right.
2 weeks from now, 4:30 on the afternoon, be here. Until next time,
We'll be back.
Dr. Gwaine,
See, that was my
Dr. Mark
attempt at a
Vaughn.
joke. All right.
telling you to stay in good health.
Doctors, thank you for another informative session. Auburn Medical Group is located in Auburn, California, USA. Thank you for participating. Please tell a friend and join us again next week.